Hi, everyone. It's like, y'all are awake, right? We're talking about sex work. We're talking about sex and drugs. Wake up. All right, great. These are my disclosures. And I wanted to start with the acknowledgement of the transgender people and the people living with HIV who gave generously of their time, their experience, and their bodies for the purpose of research, and we're grateful for their contribution to this work. I wanted to start off with a little bit of terminology, similar to some of the earlier speakers that talked about the great deal of diversity in the populations that they're talking about. If you're talking about transgender people globally, there's controversy around whether the word transgender is even the right word to use to describe the population that we're talking about. So for the purposes of understanding what I'm going to say in the next 10 or 15 minutes, I wanted to make sure that we were on the same page with some of the words I'll use. So the first word is cisgender, sometimes abbreviated cis. That means someone whose gender identity aligns with the sex they were assigned at birth. So someone who is assigned female at birth and identifies as a woman. And then transgender is somebody whose gender differs from their sex assigned at birth. Always refer to people by the gender that they identify with. So a trans feminine or trans woman is someone who might have been male assigned at birth and lives as a woman, vice versa for trans masculine people. And there's a growing population in the United States and globally of people who identify as non-binary. So neither male nor female or a combination of that or somewhere outside of the gender binary. So now that we're on the same page with terminology, there's been actually a growth spurt in data on transgender health. Sari Reisner and colleagues published a systematic review of the global health needs of transgender populations around the world, and you can see on the left the sort of exponential number of studies that took place after 2012. This happened to coincide with the publication of an Institute of Medicine report on the needs of LGBT populations that highlighted the lack of data that was available on transgender people. Most of the data that was available was from North America, particularly the United States. You can see in the chart to the right the types of issues that were covered, with sexual and reproductive health being the second most common topic that was covered in the literature. The vast majority of data was on transgender people assigned male sex at birth. And among sexual and reproductive health, most of those studies were on HIV and STIs. So now I'm going to dive in to what we know about the different subpopulations. In keeping with the fact that most of the data we have on HIV and STIs in transgender populations is among trans women, I'll start there. Our team did a global meta-analysis that was published in 2013, looking at all the data from 2000 to 2011. We found data from 15 countries, over 11,000 trans women with a pooled HIV prevalence of 19%, 49 times the odds of HIV in reproductive age adults, and this is laboratory-confirmed HIV studies. There were no data from sub-Saharan Africa or Central Asia and Eastern Europe. We updated that review a few years later to see what had been published in the 3 years following that. We included self-report and laboratory-confirmed data for that one. There were 50 new studies published, mostly among transgender women outside the U.S. The highest prevalence was among young people and transgender women of color. And there are 3 incidence estimates that had been published. 1 to 2 to 3 to 3.6 per 100 person years incidence rate of HIV among transgender women, also incredibly high. Only 8 studies really looked at the syndemic drivers of HIV, despite there being 50 new studies published, and there was still no data from sub-Saharan Africa or Central Asia and Eastern Europe. So basically what we see is that in parts of the world where the HIV burden is the greatest, it's where we have the least amount of data about HIV among transgender populations. So what our team decided to do was take a look at the data that we already had. So we had a growing amount of data that was collected in sub-Saharan Africa among men who have sex with men. And these studies were tailored for men who have sex with men. But they did not exclude transgender women. The inclusion criteria was that they be assigned male sex at birth. So we went back to look and say, well, how many transgender women actually participated in these studies? And when we did that, we found that 20%, so 1 out of every 5 of the people who participated in these MSM studies actually identified as female or as a transgender woman. When we looked and compared HIV prevalence among the men who had sex with men and the transgender women in these studies, we found a big difference. The HIV prevalence was 25% amongst trans women and 14% among cisgender men who have sex with men. So in thinking about these studies where we combine data among trans women and among men who have sex with men, we can think about maybe it's the trans women who participate in these studies that might be driving the prevalence higher, and we get a more accurate picture of what's happening within each subpopulation if we don't pool the data, but we actually look at each subpopulation. We did a multivariable analysis looking at what were some of the drivers of the HIV prevalence that we saw. Violence, law enforcement, stigma, and depression were significantly associated with testing positive for HIV in these studies. Not surprising. We have some data also on STI burden. Our team looked at STI and HIV co-infection studies that had been published between 2010 and 2015. We found 27 studies that showed a high prevalence of STIs in all of the studies among transgender people. There were only 4 studies that actually addressed co-infection with HIV and STIs. All the other studies reported HIV, reported various STIs, but didn't look at where there was co-infection, which I think is a missed opportunity. All of these studies that reported on co-infection were outside of the United States, and you can see in the table where those took place. The STI co-infection rates ranged from 2.5% to a high of 13.8%. More locally in Baltimore, we conducted a study with street-based sex workers looking at police interactions, HIV, and STI-related risk. And we included a subpopulation of transgender women sex workers. We were able to recruit about 63 people, which is pretty good for a small city like Baltimore. And we found at baseline 41% of the transgender sex workers tested positive for HIV, and 44% over the course of the 12-month study tested positive for gonorrhea, chlamydia, or trichomonas. So we see high rates of STIs and high rates of HIV among transgender women sex workers. So what do we know about HIV and STIs among transgender men? Again, going back to the systematic review, there were 11 studies in that review that included transgender men, 6 in the U.S., 5 outside of the U.S., half self-reported and about half laboratory tested. And you see a range from a low of 0% in some studies to a high of 4.3%. Where we see the higher prevalence tends to be in clinic-based samples. So they looked at people who are already coming for clinical care, often STI-related care, so potentially elevated HIV prevalence because of that sample, and also where there were smaller sample sizes. So for example, the study that had 4.3% HIV was a study of 23 transgender men, and one of them was HIV positive. So we still struggle for large enough sample sizes to get good estimates for this population. Where there appears to be a higher risk for HIV is among transgender men who have sex with cisgender men. I'll abbreviate that as trans MSM. And I wanted to announce on behalf of some people in the audience that there is actually a poster session with 700 transgender men who have sex with men reporting on their PrEP uptake and persistence in the United States, and that's WEPED 443. So go check that poster out. I'm really excited to see data with a large enough sample size. When we looked at transgender men and the HIV STI co-infection systematic review, there were 5 studies among transgender men. One global study included Spain, Portugal, Latin America, and the Caribbean. 8% HIV positive, about 4% positive for gonorrhea, and this is self-reported data, and no reported diagnoses with chlamydia or syphilis. There were 4 studies from urban centers in the United States, in California and Massachusetts, so 2 places in the United States are producing most of the data that we have on transgender populations. The HIV prevalence among trans men ranged from 0 to about 10%, again, higher among clinical samples. We saw a wide variety in the rate of STIs and small sample sizes, with the highest self-reported STI rate being 81% of people reporting ever having had an STI, and this was in a sample size of 16 people using venue-based sampling, and the highest laboratory confirmed rates of STIs was 11% with rectal chlamydia in a retrospective medical chart review with 69 people. So we have a long way to go in terms of gathering enough data to really make stable estimates of HIV and STI burdens among transgender men. There's even bigger data gaps among non-binary people. So the U.S. Transgender Survey is the largest survey of transgender people in the world. Over 27,000 people participated. 35% of them identified as non-binary, representing almost 10,000 non-binary identified individuals. Their self-reported HIV status was 0.4% and varied depending on whether they were assigned female at birth or assigned male at birth. and we found no studies that identified STI data among non-binary individuals. So I wanted to get all of that data out there and really focus the last part of my talk on what are some of the drivers of HIV and STI risk among transgender populations. And similar to what you've heard described already for other key populations, we see these multi-level risks. The structural risks including lack of legal protections, discriminatory laws and policies, stigma, social exclusion and violence at the community and individual, interpersonal level, network level, high prevalence HIV and STIs among sexual partners and high risk sex work environments, and then biological risk related to anal sex and vaginal atrophy depending on the anatomical configuration of the transgender person. There are some conceptual models that take into clear account the experiences of somebody who is transgender. So there's these multi-level risks that apply to all key populations, and then there's gender-specific risk for trans people. And Jay Sebelius, who's a researcher with the Center of Excellence for Transgender Health out of the University of California in San Francisco, developed this gender affirmation framework of HIV risk among transgender women of color in the United States. And you can see that it starts with stigma, which is ubiquitous against transgender people, and if you need data on that, I have plenty of it to share with you. And this ubiquitous stigma leads to social oppression and psychological distress at the individual level, and these drive a need for gender affirmation that is not being met, that leads to high-risk context in order to try to meet those needs for gender affirmation, and I'm going to talk through what that means in a little bit. There are also some studies that look at syndemic production. So this is a table from the systematic review where we found the 8 studies that looked at the syndemic drivers of HIV and STI risk among transgender populations. Most of those syndemic studies focus on individual behavior. So they look at things like alcohol use and drug use and don't look as much at the structural and community level factors that really might drive the psychological distress, that might drive the substance use, those types of things. We did find one study that tried to bring together the gender affirmation framework with the syndemic production to help understand some of the drivers of HIV and STIs in transgender populations. The study was done by Reisner et al., and it examined the role of syndemic conditions in social gender affirmation in potentiating sexual risk among transgender men who have sex with men. This is 173 people in Massachusetts. The syndemic was defined using 6 indicators that included binge drinking, substance use, depression, anxiety, childhood sexual abuse, and intimate partner violence. Broadly, syndemics were associated with an increased odds of all sexual risk indicators in the sample. When they used gender affirmation or checked gender affirmation as a moderator, the association between syndemics and condomless anal and vaginal sex at the last encounter with a cis male partner was significant. So in short, syndemics were associated with sexual risk among transgender men who had sex with men who had socially affirmed their gender, but was not among trans men who had sex with men who had not socially affirmed their gender, suggesting that those risks among transgender men who have sex with men who have affirmed their gender is similar to what we see among gay and bisexual and other men who have sex with men who are cisgender. So what do we know about evidence-based interventions that are tailored for transgender people? We know that the data on that is very limited. There's very few evidence-based interventions. The ones that have been documented target behavior change, and included in behavior change is PrEP, so encouraging people to uptake PrEP and to be consistent in their use of PrEP. There is very little on multi-level and structural interventions, and I wanted to highlight this one study that looked at the sort of higher level environmental legal context that might drive health disparities among transgender people. So this looked at exploring legal name change as a potential structural intervention. And they examined, in this relatively small sample, transgender women who had initiated a legal name change compared to transgender women who had completed a name change, so before and after. And the group that had not changed their name yet were more likely to report postponing medical care because of their gender identity, using non-prescription injection hormones, and experiencing verbal harassment. The group that had changed their name legally were significantly more likely to have higher monthly income and stable housing, which we know are drivers of HIV and STI risk. So future pathways. I prefer to think of these as opportunities. We need more and better quality data on HIV and STIs among transgender people. And I think that there are people who are actively trying to fill that gap. We continue to need disaggregated data from transgender participants who are included within research on broader or different populations. So I still go to PubMed and I can pull up an article that says MSM and transgender women, and then I look for the data on transgender women, and I cannot find the disaggregated data. So if you include both populations, please disaggregate the data. That can be really helpful, even if the sample sizes are small. We need data on the anatomical configuration of transgender research participants. Often we see these HIV and STI-related studies, and we can look sometimes at the structural drivers, but when we look at behavioral factors, it's impossible to interpret unless we know the anatomical configuration of the transgender people who are participating in the studies. And the best way to figure out how to ask those questions is through meaningful collaboration with trans people in the community to help us understand how to talk about anatomical configurations in a non-traumatizing way. We need more and better research on drug interactions, and there are at least 2 studies that are going to look at that and being presented next week at the main conference. And we need to test interventions that combine gender affirmation with other HIV and STI prevention strategies. And there is an enormous amount of opportunity for those of you who are researchers to look at structural interventions like non-discrimination laws, transgender-specific housing programs that are being really built by grassroots communities often and being driven by advocates, to use those as opportunities to target syndemic impacts of the co-occurring multi-level drivers of HIV STI risk, and use those to document what I anticipate would be benefits in terms of HIV and STI prevention and access to care and treatment. So I flew through that because I hope we'll have lots of time for a conversation later. Thank you.